Alright, hello. I am Jeanine Concepcion. I'm a veterinary nursing student, and today I'm going to be doing a hair, skin, and nails assessment. So here I have my prop. So I'm going to be starting off with introducing myself to the patient, washing my hands, checking that their ID band matches their name and date of birth, and then I'm going to gather my equipment, which is a pen light, a stethoscope, a flash. It could be a pen light or a flashlight, and a glass of water, and I make sure I put on my gloves. And then I'm going to explain the procedure to the patient and make sure that they're understanding of what I'm going to be doing next. Okay, so firstly in the assessment, I'm going to be inspecting the head and scalp for hair distribution, lesions, and color. So stress can cause sudden hair loss, and then I want to make sure that the scalp is clean and dry. Some dandruff may be visible. Make sure that the hair is smooth and firm, somewhat elastic. In comparison with hair being dry and brittle in other conditions. I want to make sure that the hair is evenly distributed, and even if it's chemically treated, to be known of that. I want to make sure that the amount of terminal hair is appropriate for the age, and if there's any hair loss or balding, it is symmetric and appropriate with the gender that they're assigned. And I want to make sure, for male pattern baldness, and I want to make sure that there's no lesions. Okay, so next I'm going to inspect for any infestations like lice or nits and make sure that there's none found. And then next I'm going to inspect and palpate the head, or no, not the head, the skin, for moisture, temperature, pain, texture, and I'm going to make sure that the skin is smooth and even, and that there's moisture and dryness in the appropriate areas. And I want to make sure that the skin is normally a warm temperature, make sure that it's appropriate for the area. And I'm also going to be palpating for lesions and pain in that step. Okay, so next I'm going to pinch the skin to make sure that under the clavicle for turgor, and make sure that the skin bounces back with elasticity, and make sure there's no tenting, and that the recoil is usually immediate. Okay, and then next I'm going to inspect for distribution of hair on legs and make sure it's symmetric, and make sure that the amounts of terminal hair are appropriate again for the legs. And if there's any lack of hair, it's going to be that there's a lack of oxygen in the legs usually. And then so next I'm going to inspect the skin on posterior surfaces, so it's going to be the back, and make sure the skin is intact and there's no reddened areas, or any start of pressure ulcers and stuff. And next I'm going to be inspecting the skin for blanching on any reddening areas, so I'm going to press on it and make sure that if it's red, it'll go back to white, and then once I take off my hand, it'll go back to red, as you kind of saw on my hand. And then next I'm going to assess any wounds or lesions, like I said before, any pressure ulcers, and then make sure there's no lesions, or is there any healed scars or stretch marks. And then I'm also going to be telling you the grades, the stages of pressure ulcers. So stage 1 is there's like a reddened, not a bruise, but a bump, but the skin is intact still. And then stage 2, it's like a open wound already. It's a pink wound. There's no slough, and it's still minimum. And then stage 3, you can start seeing the dermis, I believe. Yeah, you can start seeing the dermis, and to make sure that wound is open, so you can already see the dermis and all the organisms under it. And then stage 4, you can start seeing the subcutaneous tissue in the wound, and there's still no flow. And then stage 5, it's a full thickness wound. You can start seeing muscle, bone. And then unstageable, it is a wound with slough, so you can't really see what's under it, so that's why it's unstageable. We are unable to stage it. Okay, so next I'm also going to check for edema and make sure that if there's any pitting or anything like that. So the grades for that is 1, it's slightly pitting. 2 is a deeper than 1, so deeper than 1, but it's not too deep yet. Then 3 is noticeably deep pit, and extremity, it looks larger because it's is fluid retention. And then 4 is a very deep pit, and then the gross edema is extreme. Okay, so next I'm gonna inspect for any signs of cancer. I'm going to be using the A, B, C, D, E mnemonic. So A is asymmetry, B is borders that are irregular, then C is color. I want to check for the color of the lesion. And then D is diameter, make sure that's not more than 1/4 of an inch. And then E is evolution, so if there's any changes over time, I'll be asking the patient, if has this mole changed over time, and then they'll tell me, so I would like to know about that. And then next, I'm going to move on to nails. I'm going to be inspecting, the hands and feet, and make sure there's no cyanosis, hygiene, and make sure the nails are clean and trimmed. And I want to make sure that the dark-skinned clients have, may have freckles or pigmented streaks under the nails. I have to keep in mind for that. And then I'm also going to be inspecting for clubbing. So there's normally a 160 degree on nails. So once there's a 180 degree and there's like spongy, like a spongy texture for the nails, that's usually an early indicative of clubbing. And I also want to make sure it's greater than 180 is more of a full clubbing. And then they could also have hypoxia, so that's why I have to make sure that their nails are good. And then I'm gonna lastly assess capillary refill. So I'm gonna be pressing on their fingertips and make sure that the refill is no more, it doesn't take as long as like 3 seconds. So it has to be immediate, and the nail beds should go back to their red color once they stop being black. I'm a Berry nursing student, and I'm going to be doing a assessment of the head, face, neck, and lymph nodes today. So firstly, here I have my prop, but most of the time today I'm going to be demonstrating on myself or like the lymph nodes and the cranial nerve testings. So firstly, I'm going to check with the patient their ID band to make sure it's synonymous with their name and date of birth. And then I'm going to wash my hands, introduce myself to the patient, and gather materials, which is gloves, a pen light, a small glass of water, and a stethoscope. And then I'm going to explain the procedure to the patient and make sure that they are consenting to what I'm going to be doing next. So firstly, I'm going to be checking the head shape, the position, the position of the facial features, and the hair distribution. So I want to make sure that the head is symmetric, round, and it's at the midline, and it's proportioned to the rest of the body. And I want to make sure that there's no visible lesions. So next, I'm going to be checking the face for symmetry. I want to make sure that both sides of the face are symmetric and that there's no palsy. I also want to make sure that there's no abnormal movements happening, like any twitches or anything like that. And then I'm going to be testing the trigeminal facial nerve by having the patient clench their teeth, and I'm going to be palpating between the temporal lobe and the mandibular muscle, and make sure that it is normal. I want to be palpating. It should be smooth, firm, and non-tender. And next, I am going to be checking the facial nerve. I'm going to be asking the patient to smile, frown, make an angry face, purse their lips, raise their eyebrows, and do a variety of facial expressions to make sure that their facial cranial nerve is functioning. Next, I'm going to be inspecting the neck. I want to make sure that the neck is symmetric, with the head centered and without any bulging masses like a goiter. And then I'm going to be palpating the carotid arteries, and I want to make sure that the carotid artery is elastic and not tender. Next, I'm going to be assessing the thyroid for enlargement. The thyroid shouldn't be palpable unless the patient is thin and tall. So it should not, if it's palpated, it should be smooth, firm, and non-tender. And usually the right lobe is about like 25% larger than the left lobe. And then next, I'm going to be assessing for the range of motion in the neck. So it should be smooth and controlled. And with flexion, there should be a 45-degree angle. So the flexion is like this. And I'm going to be asking also the patient to elongate their neck, the extension, which should be a like 55-degree angle. Okay. So next, I'm going to be palpating the lymph nodes, and I'm going to be stating all the lymph nodes into positions now. So starting with the preocular, that is in front of the ears, so it should be around here. And then the postocular is behind the ears, so it should be around here. And then the occipital nodes are posterior base of the skull, so it should be, you know, around here at the base of the skull and the back. And then the submandible are in the medial border, so it should be like around here, like here where, yeah, around here on the neck. And then the submental is about a few centimeters from the tip of the mandible, so it should be like right here around the chin, a little bit in this area. And then the superficial cervical nodes are superficial to the sternocleidomastoid muscle, so it should be like right here, almost like where the jugular would be, like so, around here, like that. I'll be palpating like this, all the nodes. And then the posterior cervical nodes is posterior to the sternocleidomastoid again, and anterior to the trapezius, so it should be like around here. So that's how I would be palpating the lymph nodes. And then we have the deep cervical choanoids, which is around the sternomastoid muscle, this one. So it should be like, again, like right here. So that's not to be confused with the superficial cervical, which is up here. And then the deep cervical should be more down. Okay. And then the supraclavicular node, you would hook the fingers over the clavicle and feel deeply between the clavicles and the sternocleidomastoid muscle. So like this. Yeah, so hooking the fingers. And you should know that the lymph nodes shouldn't be swollen or enlarged or tendered. So next, I'm going to be testing the cranial nerve, the spinal accessory node, and then how you test that would be putting pressure on the muscles and having the patient lift up with resistance, or yeah, that's usually how it is. So it should shrug shoulders against resistance, or you can also turn the head against resistance. So that's how you would test the spinal. I am a veterinary nursing student, and right now I'm going to be doing a neurological assessment. So the purpose of a neurological assessment is to test efferent and afferent pathways within the cranial nerves. So firstly, I'm gonna, like always, check the ID band to make sure it's synonymous with the patient's ID and date of birth and name. I'm gonna wash my hands, introduce myself to the patient, gather my equipment, which is a gloves, pen light or a flashlight, a small glass of water, and a stethoscope. And then I'm going to explain the procedure to the client to make sure that they are consenting to what I'm going to be doing next. So the first cranial nerve that I'm going to be testing is the olfactory nerve. So that is with the smell. So I'm going to be having the patient smell something familiar or close eyes to identify the smell. So they'll be closing one nostril and smelling, and then the other, and making sure that they're both efficient. All right, so next I'm going to be checking the optic nerve. So I'm going to be using a Snellen chart, or like a Snellen chart, and then having like them close one eye and close the other, and make sure that their vision isn't impaired. And it's going to be without contacts and without glasses. So next I'm going to be checking the oculomotor, the trochlear, and the abducens cranial nerve. So that's going to be 3, 4, and 6, and make sure that they all work together with eye movement and eye dilation. So I'm going to be checking them all together. So the oculomotor is you're going to be checking with a pen light. So you'll check for the patient. Well, I can use a prop, but like again, their eyes are not going to be moving. So for the oculomotor nerve, you're going to be going up and down to check their the eye movement. The trochlear is going to be medial and down. So medial and down, like that. And then the abducens is lateral, so it's going to be to the sides. So usually you could use an H pattern, so like that, to check all the nerves at once. And like I said again, the oculomotor which is cranial nerve 3, has to do with dilation as well. So you could always check with the patient and lift and make sure that they are dilating, and then while we have the light on one eye, the other one should also dilate as well to make sure they're both efficient. Okay, so the next nerve I'm going to be checking is a trigeminal. So like that, we do light touch and sensory. So I mean, you know, motor and sensory function. So I'm going to be asking the patient to clench their jaw, and I'm going to be palpating between the temporal and the mandible to make sure that it is functioning. And then I could also check with a cotton ball to do light touch over the face and make sure that the patient is identifying where the cotton ball has been swiped with their eyes closed. Okay, so next I'm going to be doing the facial nerve, which is the facial cranial nerve. So I'm going to be asking the patient to do a bunch of facial expressions like smiling, blinking, putting an angry or upset expression, and just checking that the whole face is working. All right, so next I'm going to be doing the Vester-Cochlear, which is the hearing test. So it's the beeping test. So usually it'll be a beep, and then they will raise your hand once they hear the beep, or saying words at a distance. So I'll be behind the patient and then whispering like a phrase like 1 2 3, 3 2 1, or a random set of words, and then make sure that they could hear me from either side of their head. So you could also use, like I said, the Weber test or the Rini test for either or. And that also uses a tuning fork. So you would place the tuning fork on the middle of the head and make sure that they could feel the vibration, or also at the base and then at the ear to make sure that they know that the tuning fork is heard best at the ear. So next I'm going to be testing the glossopharyngeal nerve and the vagus nerve at once. So they both have to do with swallowing. So how testing the motor function is basically swallowing water, and then also testing the gag reflex to make sure that they can gag. You use that after surgery to make sure that a patient can eat or drink. And then it's with taste, so maybe like a familiar taste as well. You could check those cranial nerves. So next, it's the spinal accessory nerve. So how to test the spinal accessory nerve is to have the patient shrug against resistance or turn their head against resistance. Okay, so next I'm going to be checking the hypoglossal nerve, and that's the tongue. So I'm going to be having the patient move their tongue from side to side and then repeating sentences to make sure that their speech isn't slurred. Okay, so next I'm going to be evaluating gait and balance. So it's asking the patient to do like certain walks. So it's either toe walk or toe to heel walk. So that'll be asking the patient to do like the test where they heel to toe, so with their arms out to make sure that they don't sway, and then also to have the patient close their eyes and then stand and make sure they don't sway and they don't have to catch themselves when they sway. You could also do the I think it's called the heel to shin. Yeah, the heel to shin to make sure that they have balance, or also the finger to nose from different angles to check that. Okay, so assess the coordination. Also, again, like what I said, the finger to nose and then heel to shin. So those are the tests for coordination when you do that. And then I'm also going to be doing the Romberg test. So it's closing their eyes and staying with good posture, like I said, those tests. Okay, so then I'm going to be assessing light touch, pain, and temperature. So with eyes closed, it's the cotton ball test, like I said again. I'm going to make sure that they know where it is. And then you can also use a tongue stick with a sharp end and a dull end, and then you would go around the body to make sure that they know which is sharp and which is dull with their eyes closed. And then tuning fork to toes as well can be used. Okay, so next, well, like I said, the vibratory sensation would be tuning fork to toes or to the fingers, like the top of fingers. And next, I'm going to be doing the sensitivity to position, testing that. So I'll be moving the joints around to make sure, with the fingers, pulling the thumb away to make sure that there's no uncomfortability when they move the joints. So next I'm going to be doing tactile discrimination, which is fine touch, which is with their eyes closed. I put a unknown object in their hand and make sure that they could, like a key or a paperclip, and make sure that they could distinguish what that is. And then point localization, I would be pointing with their eyes closed. I'll be pointing at a specific point of the body and they must identify it. And then I'm going to be testing graphification, which is with the eyes closed. I would draw something on the patient's hand, so like a circle, a heart, a triangle, a square, and they would have to determine what I'm drawing, what I'm tracing with in their hand, their palm of the hand. All right, and then testing 2-point discrimination will be touching 2 different parts of the body at the same time and having them identify which 2 parts of the body were touched. And then next is the deep tendon reflex. So with the reflex hammer, I would be feeling for the bicep. So you would be putting the thumb, and then with the stethoscope or reflex hammer, you're going to be hitting the thumb and making sure that there's a joint. Okay, and then the brachioradialis would be a little bit more down. Then the triceps, you could either do it with hanging off like that, or from the back, you would hit the back to make sure that there's a feel for a contraction. And then the patellar, which is right here, the knee. So I would hit the knee, make sure that there's a contraction, or the Achilles, which is back here. It's the ankle. I would hit here and make sure there's a contraction as well. All right, so next I'm going to be checking the plantar reflex with the Babinski test. So I would be running the reflex hammer or something else around the sole of the foot to the heel of the toes, and making sure that there's no adverse reaction, which could indicate a neurological effect. And then I'm going to test for meningeal inflammation. So that is the Babinski or the Kernick sign. So the neck flexion, without flexing the knees. So that's the Babinski, would be flexing the neck and making sure the knees don't go up, which also again is an indicative for meningitis. And the Kernig would be elevating the leg with the other leg straight. So elevating the leg with the other leg straight and making sure that the other leg does not elevate, because that's also another indication for meningitis. Okay, so that seems to be it. Thank you so much.